I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G.
Today, we're talking about a huge topic, something that affects every single woman, yet surprisingly, most people know very little about it. That's right, it's menopause. Now, menopause is something that every woman will experience, yet despite that, there's still a whole lot of confusion around it. How do we diagnose it? What are the symptoms? And what are our management options? Well, fear not. We're here to break it down and make menopause easy to understand.
Now, because it's such a huge and important topic, we want to give menopause the time it deserves, so we're going to run this as a mini-series. This week, we'll talk about the definition and physiology of menopause, the symptoms of menopause, and the long-term consequences. You might think menopause is all about hot flushes and mood changes, but there is so much more to it. So let's start off with a definition. First of all, what is menopause?
Menopause is defined as permanent cessation of menstrual periods. Technically, the menopause is the final menstrual period. Now, the problem with this is that you can't actually tell which period is your last until 12 months have passed without any more bleeding. So this makes menopause a retrospective diagnosis. We can diagnose menopause after a woman has experienced 12 months of amenorrhea without any obvious pathologic or physiologic cause.
So, why does menopause happen?
Menopause typically occurs because of complete or near complete ovarian follicular depletion. So basically, once a woman has run out of eggs. All women are born with a different number of eggs, and that number sits somewhere between 1 and 2 million. By puberty, you've lost about 75% of those eggs, leaving you with something like 500,000 eggs. And from puberty to menopause, the number of eggs continues to drop through ovulation and atresia until you end up with 0. Now, the rate of loss isn't constant over time, and there's no way for us to predict how quickly someone might lose their eggs. What we do know is that the rate of loss accelerates from age 37, and that by age 40, most women are down to about 3% of their ovarian reserve. Your age of menopause depends on the number of eggs you start with and the rate at which you lose those eggs. Now, eggs can be depleted naturally, through surgical removal of the ovaries, or through medical treatments like chemotherapy or radiation therapy.
So why is this a problem? What happens when we run out of eggs?
Without oocytes, there are no follicles, which results in a lack of estrogen since estrogen is produced from follicular cells. This lack of estrogen feeds back to the hypothalamus and pituitary glands, which increase the secretion of follicular stimulating hormone, FSH, in response. Now, FSH normally acts on the follicular cells in the ovary to tell them to produce more estrogen and progesterone. But without follicles, there's nothing for the FSH to act on, so you end up with a high FSH but a low estrogen and progesterone. In fact, through menopause, women lose about 90% of all estrogen production. Low estrogen leads to the symptoms of menopause, but can also worsen and accelerate disease processes, leading to some longer-term complications like cardiovascular disease, osteoporosis, and increased risk of diabetes.
On that note, is there any way for us to be able to predict when menopause will happen?
Well, basically no. There is no reliable way to predict when a woman will experience natural menopause, although that's not for lack of trying. Several studies have tried to address this question through the creation of prediction models using a variety of inputs like AMH, hormone levels, period regularity, menopausal symptoms, and even life habits. Unfortunately, these models aren't accurate enough to predict the timing of natural menopause with any degree of certainty.
I read one of those studies, and hilariously, what they noted was that women tended to increase their self-reported alcohol consumption when approaching the age of natural menopause. Not that drinking alcohol is a cause of menopause, more so that it seems to be a coping mechanism that women use to deal with menopause. Ladies, we get it.
So while we can't predict when natural menopause will occur, there are some factors that we know to be associated with the age of menopause. One of these factors is the age at which your mother went through menopause. Women tend to experience menopause at a similar age to their mother or their sisters, and there are some genes that are associated with the age of menopause. One of the most well-known genes is the Fragile X FMR1 premutation. This particular gene is associated with premature ovarian insufficiency and an early age of menopause by up to 7 years. Ethnicity and race may also affect the age of menopause. Natural menopause seems to occur earlier in Hispanic women and later in Japanese American women when compared with white women. Smoking is thought to cause menopause up to 2 years earlier than in people who don't smoke. And hysterectomy appears to alter ovarian function over the long term as well, even if the ovaries are conserved. It's not exactly clear why, and the data only comes from observational studies that used hormonal profiles and menopausal symptoms as the markers for menopause, but it seems that women who undergo hysterectomy may develop menopausal symptoms earlier than those who did not have a hysterectomy, generally somewhere in the realm of 1 to 2 years. And sadly, again, for us obstetricians, night shift work may also impact the age at menopause. Man, we do not get paid enough to do night shift.
Now, when do most women go through menopause?
The average age of menopause in Australia is about 51, but it's generally considered normal for menopause to occur somewhere between the age of 45 and 55. Menopause that occurs between 40 and 45 years is known as early menopause, which occurs in about 5% of women. And menopause that occurs before the age of 40 is known as primary ovarian insufficiency, which occurs in about 1 to 3%. Late menopause is defined as menopause after the age of 55, and this occurs in 5% of women.
So does menopause just come out of nowhere, or do women get some kind of warning?
What you're referring to is perimenopause, also known as the menopausal transition. Perimenopause begins on average about 4 years before the final menstrual period. However, this time can last as long as 10 years. In perimenopause, a number of physiological changes occur that might affect a woman's life. As we start to run out of eggs, we tend to get anovulatory cycles, which can lead to irregular menstrual cycles and changes to the bleeding pattern. There can also be marked hormonal fluctuations resulting in hot flushes, sleep disturbance, mood symptoms, and vaginal dryness. In addition, changes in lipids and bone loss begin to occur, both of which have implications for long-term health. Almost all women experience the menstrual irregularity and hormonal fluctuations prior to menopause, but the degree to which some is affected can vary.
Now, for those research nerds amongst us, the reason we know about what happens during perimenopause is thanks to a series of longitudinal cohort studies on midlife women. The largest of these studies was called the SWAN study, the study of women's health across the nation. This study followed 3,000 multi-ethnic women aged 42 to 52 for 15 years, and data from that study helped us to extrapolate what many women experience as perimenopause.
Menstrual cycle changes are amongst the most common change that women will experience as they enter the perimenopause. Menstrual cycles are often still ovulatory, which is why contraception is still so important. However, the follicular phase begins to shorten, meaning that periods can often occur closer together. The early transition into menopause is defined by a change of more than 7 days in the intermenstrual interval. Normal menstrual cycles should be between 25 to 35 days. During the menopausal transition, this may increase to 40 to 50 days, or there can be a shortening of the intermenstrual interval. After the initial lengthening of the menstrual interval, women progress to more dramatic menstrual cycle changes with skipped cycles, episodes of amenorrhea, and an increasing frequency of anovulatory cycles. This stage typically lasts for 1 to 3 years before the final menstrual period.
There is a staging system called the straw staging system, which tries to describe the expected changes before, during, and after perimenopause. This is called the Stages of Reproductive Aging Workshop and was established in 2001 by a group of professionals with a special interest in menopause. More recently, this staging system was modified to the straw plus 10 staging system. Basically, it classifies the adult woman's life as reproductive, perimenopausal, and postmenopausal.
So, can't we just run a hormone profile and check whether someone is going through the menopausal transition, or can we not do that?
Hormone testing is generally not needed in the diagnosis of menopause or perimenopause. A clinical diagnosis can usually be made on the basis of menstrual changes, menopausal symptoms, and age. If these changes occur before the age of 45, then hormonal testing can be useful to confirm the diagnosis, especially of primary ovarian insufficiency. But aside from that, there is no role for hormone testing. The reason is because perimenopause is characterized by dramatic fluctuations in serum FSH and estradiol concentrations. So you might take one test that shows a high FSH and low estradiol levels consistent with menopause, but then you take that test again 2 days later and the FSH and estradiol might be in the normal premenopausal range, and then the next week the levels might be off the charts. So essentially, hormone profiles are pretty useless and are only good for telling what the woman's hormones are doing at one point in time, but not for telling you whether the woman is menopausal or not. The exception to this rule is in women who are amenorrheic for other reasons. For example, they're on the Mirena or they've had an endometrial ablation or a hysterectomy. In these cases, it can be really difficult to determine if someone is menopausal or not. For patients on the Mirena, you could consider removing the Mirena and using clinical indicators like whether they return to menstruation or not, or menopausal symptoms to make a clinical diagnosis. For those without a uterus or endometrium, you can use a serum FSH as a rough guide, keeping in mind that it's not absolute and it can fluctuate.
Other hormonal changes that occur during the menopause transition include a progressive decrease in serum inhibin B, as well as a decrease in anti-Müllerian hormone, or AMH. In addition, the antral follicle count steadily declines as a woman heads toward menopause. Whilst AMH, the antral follicle count, and hormonal levels are used to assess ovarian reserve in the setting of infertility and fertility, none of these are validated for the evaluation of menopausal status. Inhibin B is typically measured during a diagnostic evaluation for ovarian tumours, but not for evaluation of menopause.
And just a quick refresher for what these things are. The antral follicle count refers to the number of small follicles visible on ultrasound in the first few days of the menstrual cycle and represents the follicles that have been recruited that menstrual cycle. Anti-Müllerian hormone, or AMH, is a hormone produced from these antral and preantral follicles and correlates to the ovarian reserve. And inhibin B is a hormone that's released from the granulosa cells of the larger and more developed antral follicles that acts to inhibit FSH production. Obviously, all three of these markers reduce with age.
So apart from menstrual changes, which obviously eventually result in complete cessation of periods, what other symptoms can we expect to experience through the menopause transition?
Hot flashes are by far the most common symptom experienced by women, occurring in about 80%. Hot flashes are also called hot flushes or vasomotor symptoms. When hot flushes occur at night, they're typically described as night sweats. Hot flushes begin as the sudden sensation of heat on the upper chest and face that rapidly becomes generalized. The sensation of heat lasts from 2 to 4 minutes, is associated with profuse sweating and occasionally palpitations, and is sometimes followed by chills, shivering, and a feeling of anxiety. These hot flushes can occur several times a day, but are particularly common at night. Hot flushes can have a significant impact on sleep, concentration, mood, energy, and sexual activity. The more severe the vasomotor symptoms, the more daily activities are impacted.
Do we know why hot flushes occur?
Hot flushes are caused by estrogen withdrawal and are mediated by thermoregulatory dysfunction at the level of the hypothalamus. Basically, loss of estrogen causes your brain to be worse at regulating your body temperature. Now, the estrogen withdrawal is the important factor here. You'll notice that young girls below the age of puberty don't get hot flushes. These children have very low levels of estrogen, and yet they don't experience hot flushes, proving that low estrogen alone is not enough for hot flashes to occur. It seems you need to be exposed to adult levels of estrogen first, and then have withdrawal of that estrogen, and that's what's necessary for hot flashes to occur.
So interestingly, male to female transgender people who decide to stop their estrogen would also experience hot flashes.
Exactly. In the premenopausal state, the body initiates mechanisms to dissipate heat when the core body temperature increases by 0.4 degrees Celsius. In menopausal women, this happens with much lower increases in temperature. The feeling of warmth happens because of inappropriate peripheral vasodilatation and increased blood flow to the skin. Sweating results in rapid heat loss and a decrease in core body temperature below normal, and this can then result in shivering as a normal mechanism to increase the body's core temperature back to normal. Basically, your body temperature goes up 0.1 of a degree, your brain then overreacts and says, oh my God, we're overheating, and causes your blood vessels to dilate and you start to sweat. Then your temperature drops too much and your brain says, oh my God, we're freezing, and immediately causes you to shiver to raise your core body temperature again.
Great. What a dumb system. Who put that design flaw in our bodies?
Well, we finally have something to blame, and that's kisspeptin, neurokinin B, and dynorphin. These are the neurons that mediate the thermoregulatory changes that cause hot flushes, and they shall now be referred to as our nemesis. Our nemesis live in the arcuate nucleus of the hypothalamus and play an important role in GnRH secretion. Unfortunately, these neurons are very sensitive to estrogen levels, with estrogen normally inhibiting K and D signaling. When estrogen levels fall, there is increasing activity in the kisspeptin, neurokinin B, and dynorphin neurons. This leads to oversignaling in the area of the hypothalamus responsible for thermoregulation. As a result, our internal thermostat becomes overly sensitive to small changes in core temperature, leading to dramatic responses like hot flushes, sweating, and shivering for seemingly no reason.
Ah, the joys of aging. How long can we expect to experience these hot flushes?
Hot flushes last for about 7.5 years on average, although that's not the case for all women. About 40% of 60 to 65-year-old women will still get hot flushes, and about 25% of women will have them for life. There are thought to be 4 different trajectories of hot flushes. Early onset, which are those that start early in perimenopause and then go away after menopause. Late onset, so those that start near the time of your last period and then get better with time. High frequency, those that start early in perimenopause and then just stay high and annoying forever. Low frequency, which is where you get them every now and then, but you're not really bothered by them. These all tend to occur with equal frequency. So it's like a lucky dip of which kind of hot flusher you're going to be.
While we can't predict which one of those 4 groups women will fall into, there are some risk factors that make the chance of hot flushes more likely. These include smoking, obesity, reduced physical activity, ethnicity, and genetic variations. Hot flushes tend to be worse in those who are overweight. Now, this is a little bit paradoxical because we know that adipose tissue results in higher serum estrogen concentrations due to increased peripheral conversion of androstenedione. Still, for some reason, obese women are more likely to have hot flushes. If you think about it, carrying some extra weight can be considered to be the equivalent of wearing a jacket. If you've got an extra layer on, of course you're going to feel it more when a hot flush hits. Weight loss can be helpful in reducing hot flushes for these women. Again, ethnicity affects the symptoms of menopause. African American women report a longer duration and more frequent hot flushes than Caucasian women, and Japanese and Chinese women are lucky and report less frequent hot flushes for a much shorter duration. There are also genetic factors that determine the severity of hot flushes. Women who have variations in the gene that codes for tachykinin receptor 3 are more likely to experience hot flushes than women without those variations. Tachykinin receptor 3 is the gene that encodes the neurokinin B receptor. This is an important point to remember because it will come up later when we're talking about treatment for hot flushes. Hot flushes are also not completely benign. They have been linked to heart disease and a 3 times higher risk of depression. Although most women describe their symptoms as severe, interestingly, only about 20 to 30% of women with hot flushes actually seek treatment.
Now, I just want to talk a little bit about hot flushes. It's really important that you don't always attribute hot flushes to menopause. Certainly, menopause is the most common cause of hot flushes, but there are also some other important conditions that can present this way. Certain conditions like carcinoid syndromes, pheochromocytoma, POTS, thyroid cancer, and renal cancer can all cause hot flushes. If you have a woman who never experienced hot flushes in perimenopause or early menopause, and she comes to you in her 70s with new hot flushes, it's pretty unlikely that those would be due to menopause, and you should probably look for another cause. Other causes of hot flushes are varied and include substances like alcohol, diltiazem, nicotinic acid, levodopa, bromocriptine, and even some SSRIs. And there are a bunch of different medications that can trigger hot flushes as well. So if in doubt, make sure to check those out.
All right, so we've covered hot flushes. Let's move on to the next most common symptom of menopause, mood symptoms. Mood symptoms are really common in menopause, with about 1 in 3 experiencing significant mood changes. Mood symptoms are typically manifested as irritability, hostility, and rage, but can also include anxiety, low mood, or feeling overwhelmed. That sounds great. Women might also describe a feeling of disconnect, like they're not present or able to engage with those around them. Often these symptoms can be quite out of character for the woman. Mental health changes can occur up to 5 years before hot flushes appear. So it can be really difficult to determine whether a woman has primary depression or anxiety, or whether her mood symptoms are related to the hormonal changes of perimenopause, or, in some cases, both.
Now, to add to the burden on mental health changes around menopause, there is also a significantly increased risk of new onset depression in women during the menopausal transition. That means women who have never struggled with their mental health before might suddenly develop depression or anxiety in their mid-40s. This risk is particularly high for women with a history of mood disorders or those who have experienced PMDD or postnatal depression. And this makes sense since these women have already demonstrated that their brains are more sensitive to hormonal fluctuations. Sadly, suicide rates are highest for women around age 45 to 55, which correlates with this increase in mood changes. So mood changes are not something that should be ignored or taken lightly.
Now, there are a lot of contributing factors to mental health around the time of menopause. Often, women are at the peak of their career and maybe in positions of leadership or seniority and have stresses with work. Then there's the challenge of caring for adolescent children, aging parents, or both. There might be relationship issues or marriage breakdown. And often women are dealing with the physical changes of aging with weight gain and general health decline, which can lead to reduced self-esteem and body image. And then we throw the hormonal impacts of menopause on top of all of this.
Now, there is a bit of neuroscience behind all of these hormonal changes. We've all heard of serotonin, dopamine, and noradrenaline, right? Well, there are many neurotransmitters involved in these systems in the brain that all influence behavior, cognition, and mood. And guess what? These neurotransmitters are modulated by estrogen. Estrogen modulates serotonin, dopamine, and noradrenaline systems, which are responsible for happiness, motivation and reward, and our stress response. Fluctuating estrogen can cause instability in these neurotransmitter systems, leading to mood swings, irritability, anxiety, and depressive symptoms. Estrogen also influences the hypothalamic pituitary adrenal axis, which is responsible for the body's stress response. Altered estrogen levels are thought to increase the HPA axis reactivity, which can increase our stress response. Now, you might think that if this is the case, then surely every woman would get mood changes, but we know it's not the case, right? So there's a second part to this, and that depends on how sensitive your brain is to changes in hormones. And that, my friends, depends on your genetics, the amount of estrogen and progesterone receptors you have in your brain, how sensitive those receptors are, the stresses you've been exposed to, and basically, it's complex.
And since we've just learned how estrogen can affect neurotransmitters that lead to mood changes, it's not too much of a stretch to realize that these hormonal mediated changes in neurotransmitters can also lead to altered function of the brain. Cognitive changes are experienced by many women in perimenopause and are commonly described as forgetfulness, difficulties with word retrieval, and brain fog. The science behind this is terrifying. Lower estrogen reduces the brain's synaptic plasticity and neurogenesis, which basically means that the brain is less able to adapt and form new neural connections. Couple this with altered neurotransmitter activity, and that leads to impaired memory and attention.
I just want to point out that even though women going through menopause experience all of these cognitive changes and feel like their brain isn't functioning as well as it used to, they have still been proven to be smarter than men. A cross-sectional study of over 200 men and women aged 45 to 55 showed that women in their late reproductive or perimenopausal years outperformed age-matched men in detailed memory tasks. There appears to be an association with serum estradiol concentrations and mental performance. Some evidence suggests that in early midlife, women can outperform men on memory tasks, but with the onset of menopause and decline in serum estradiol, any memory advantage diminishes. So basically, menopause just levels the playing field.
Sleep disturbances are... Actually, sorry, before I say that, that's so great. I'm just like,
I know.
Loving that fact.
We're not dumb, you're just the same as a man.
Great fact.
Oh, so good.
You're not dumb, you're just the same as a man.
Okay, okay. Sleep disturbances are also common, with women either not being able to fall asleep or waking in the early hours and not being able to get back to sleep. Hot flashes can also contribute to this, but even in their absence, sleep appears to be impacted in the perimenopause. About 40 to 45% of women report difficulty sleeping in the perimenopause. Now, sleep disturbance is multifactorial and could be due to a variety of things like sleep apnea or restless leg syndromes, for example. Mood changes like anxiety impact sleep, as does a more sensitive HPA axis, which can lead to secretion of cortisol. And with higher stress levels, it's also harder to sleep. Once again, estrogen withdrawal is to blame, with the loss of estrogen leading to changes in melatonin secretion, but progesterone also plays a part here. Progesterone has sedative, calming effects through the GABA system, and declining progesterone is also at fault.
Joint and muscle pain become increasingly common through menopause because, you guessed it, there are estrogen receptors in the joints. Loss of estrogen leads to thinner cartilage, increased inflammation in the joints and tendons, and a reduction in bone density. This can change the mechanics of joints, leading to discomfort. Estrogen also impacts the muscles with declining levels, leading to muscle weakness and reduced tendon flexibility, affecting joint support and increasing the risk of pain and injury. Then there's inflammation, and a new term I learned this weekend called inflammaging, which is basically an age-associated shift towards a more pro-inflammatory state. And as we all know, inflammation is bad and can exacerbate joint symptoms and other inflammatory conditions like arthritis, for example. There also tends to be an increased incidence of rheumatological conditions that occurs around the same age that women go through menopause. So sometimes it's not clear whether the joint and muscle pain is due to estrogen deficiency or due to another medical condition. What we do know, though, is that joint pain and stiffness does tend to improve with estrogen supplementation, suggesting that estrogen deficiency may play some role in exacerbating joint condition.
Genitourinary symptoms are also a common feature of menopause and are defined as a collection of symptoms and signs caused by hypoestrogenic changes to the labia, clitoris, vagina, urethra, bladder, and pelvic floor muscles that occur in menopausal women. All of these tissues contain estrogen receptors, and with estrogen deficiency, what we see is thinning of the tissue, a loss of epithelium, and even shortening of the vagina. This can result in symptoms like dry vagina, painful intercourse, urinary urgency, and recurrent UTIs. In general, these symptoms tend to develop later than other menopausal symptoms like hot flushes, typically kicking in after the age of 50 or even in the 60s. Estrogen deficiency leads to a reduction in blood flow to the vulva and vagina, which is a major cause of decreased vaginal lubrication and sexual dysfunction in menopausal women. Women with genitourinary symptoms may also experience vaginal dryness, painful intercourse, and urinary urgency. There is even an association with recurrent UTI due to a lack of estrogen.
Women who tend to get menstrual migraines may unfortunately experience a worsening in frequency and intensity of these headaches in the perimenopause. This is usually due to rapid fluctuations in estrogen levels. In perimenopause, women tend to fluctuate between estrogen deficiency and estrogen excess. While migraines are commonly attributed to estrogen excess, the sudden changes in hormone levels are also well known to be a trigger.
So we've discussed the definitions of menopause, diagnosis, and the common symptoms. But there's a lot more to menopause than some uncomfortable symptoms and the cessation of periods. What about the long-term effects of estrogen deficiency?
The main long-term consequences of estrogen deficiency include osteoporosis, cardiovascular disease, and metabolic changes. These long-term effects start to creep in after the age of 60.
Osteoporosis is one of the big ones. Bone loss begins during the menopausal transition, with the highest rate of bone mineral density loss occurring in the year before the final menstrual period, through to 2 years later. Bone loss is accelerated at perimenopause and menopause due to estrogen deficiency. Estrogen normally functions to inhibit osteoclast activity, reducing bone resorption and promoting osteoblast activity, which supports bone formation. During menopause, the loss of estrogen removes the inhibitory effects on osteoclasts, resulting in increased bone resorption, which outpaces the rate of bone formation. The result is a net loss of bone mass. Reduced bone mineral density in osteoporosis is important because it increases the risk of fractures, especially in the spine, hips, and wrists. And it affects a lot more women than you think. 1 in 3 women will have an osteoporotic fracture in their lifetime, and 1 in 6 women will have a hip fracture. Hip fractures are especially important because we know that these kind of fractures are associated with significant mortality. About 20% of women will die within 1 year of a hip fracture.
The risk of cardiovascular disease also increases after menopause, not only due to age, but also due to estrogen-mediated effects on cholesterol. Cardiovascular disease is incredibly important because it remains the biggest cause of death in women. Loss of estrogen leads to changes in the lipid profile, with postmenopausal women often showing higher total cholesterol, LDL cholesterol, and triglycerides, and a lower HDL cholesterol. These changes promote atherosclerosis, which eventually increases the risk of cardiovascular disease. Atherosclerotic changes, coupled with the loss of estrogen's vasodilatory effects, leads to arterial stiffening and a rise in blood pressure. These are all exacerbated by the known metabolic changes in menopause.
The most well-known metabolic change of menopause is the change in body fat distribution. The body composition changes with a reduction in muscle mass and increased visceral fat. This one is interesting, and I once heard it described to me in an interesting way. Basically, your body can produce estrogen from fat cells, and so when you enter a state of estrogen deficiency, like in menopause, your body preferentially stores fat, especially around your stomach, in an effort to increase estrogen production. So basically, you can have a woman who has had a healthy diet and exercised her whole life, who continues her same routine through the menopause, but still puts on weight. What the hell? In general, postmenopausal women will put on about 500 grams of weight per year. Other metabolic changes include impaired insulin sensitivity, increasing the risk of type 2 diabetes. Skin changes also occur due to a loss of collagen, reduced skin thickness and elasticity, lower moisture retention, drier skin, and slower healing, resulting in thinner, drier, less resilient skin prone to wrinkles and sagging.
Okay, time for a summary. Menopause is the final menstrual period and is caused by ovarian follicular depletion. A diagnosis of menopause is made retrospectively after 12 months of amenorrhea. Hormone testing is not required to diagnose menopause and is actively discouraged except in the case of primary ovarian insufficiency.
The timing of menopause depends on the number of eggs you have at birth and the rate of follicular decline, and there's currently no way to accurately predict the time of natural menopause. Factors that affect the time of menopause include genetics, ethnicity, smoking, night shift work, and a hysterectomy.
The average age of menopause is 51, but normal menopause can occur from age 45 to 55. Early menopause occurs between 40 to 45, and primary ovarian insufficiency is when menopause occurs under the age of 40. Perimenopause begins about 4 to 10 years before the final menstrual period and is characterized by irregular menstrual cycles, marked hormonal fluctuations, and menopausal symptoms such as hot flushes.
Common symptoms of menopause include vasomotor symptoms like hot flushes, night sweats, and palpitations, mood symptoms like irritability, anxiety, depression, and hostility, cognitive changes like brain fog, memory loss, and reduced attention, sleep disturbance like difficulty falling asleep, difficulty staying asleep and waking in the night, joint and muscle discomfort with backaches or pains. Genitourinary symptoms include vaginal dryness, urinary frequency, dyspareunia, and recurrent UTIs.
Long-term consequences of menopause include osteoporosis, cardiovascular disease, and metabolic changes like increased body fat, insulin resistance, and high cholesterol.
Okay, well, this has been a very negative episode so far with all the horrible things that can happen to you during menopause. You know, I heard the other day about the 3 Ps of a woman's life: puberty, pregnancy, and perimenopause. With puberty and pregnancy, the downsides are usually balanced by the good. With puberty, sure, you might get acne and periods and all these mood changes, but that's also balanced by discovering new relationships, exploring sex, and getting boobs. With pregnancy, obviously you get a baby at the end of it, but where's the bright side of going through menopause? Surely there's something for us women to look forward to.
I think ultimately the reason there seems to be more negatives than positives in menopause is because menopause is the result of aging. And unfortunately with aging comes a decline in our health and in our organ function. The ovaries are the first organ to naturally fail with age. That's quite confronting, especially because it's now occurring in the peak of our lives. We've got our jobs sorted, our family's complete, we might have a house. Finally, everything you've worked hard for seems to be on track. And then you're hit with a massive reality check that you're getting older. And often realizing that it's the first time a woman might be faced with the reality of her own mortality.
Now, this is not always a negative. Sometimes the menopausal transition is exactly what a woman needs to take stock of her life and start living the way she wants to live. We see higher levels of confidence and freedom, and women feeling like they can finally start living for themselves. Often, this might be a time of awakening, and a woman might leave an unhealthy relationship or job, or start focusing on what they really want to do with their life. I think, the physical downsides of menopause aren't great, but it's a transition to a new phase of life. And thanks to our increased life expectancy, it might even be our longest phase of life. So let's try and finish this episode by focusing on the positives of menopause.
Okay, well, firstly, there are no more monthly periods, thank God. For many women, this means freedom from menstrual cramps, bleeding, and premenstrual symptoms. You don't need to worry about carrying tampons or a change in underwear. You won't get caught off guard with a surprise period, and you don't need to spend all that money on feminine hygiene products. Women might also feel more energy as a result of this, especially those who previously suffered from iron deficiency anemia due to heavy menstrual bleeding. With cessation of menstrual cycles also comes significant improvements in conditions like endometriosis, adenomyosis, and even shrinkage of fibroids. This can be a huge relief for women with resolution of pain and troublesome bleeding. Moods tend to stabilize after menopause because you don't get those cyclical hormonal fluctuations that can lead to conditions like PMDD, and menstrual migraines go away.
There's also no risk of pregnancy, so no need to worry about contraception anymore. No condoms, no contraceptive pills, no Mirena, no expense. For many women, this is very freeing and can lead to a new era of sexuality where the woman feels like her body is there for her to enjoy and no longer for the purpose of making a baby. For women who choose not to have a baby, there comes a reduction in societal pressure to have a baby once you go through menopause.
Hair tends to thin and growth tends to slow, which means no more shaving of your underarms and legs anywhere near as often.
And then there's the mind shift. I mean, obviously I haven't gone through menopause yet, but a lot of women describe just not caring about trying to people please anymore, just existing the way they are and feeling confident in themselves. Women also describe feeling more respected and more powerful. Yes, menopause can be unpleasant for many and a walk in the park for others, but it's a transition into a new phase of life, and I think it can be quite an empowering experience on the other side.
So that brings us to the end of our first episode on menopause. Thanks for listening to this week's episode of the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. Find us on Instagram or Facebook, or email us at theuterinesound@gmail.com.